26.
This conference will now be recorded.
We'll go ahead and start. Welcome to the June 2026 NASCI Curious Case webinar. These webinars are meant to be informal and interactive, so please feel free to respond to my questions and ask your own if you have any. Since we last I did it in December, I've had a few interesting cases, and I'll try to bring them over here. These are cases that either I have seen or my colleagues at University of Rochester have seen, and these have all been educational. So I thought this would be great to talk about these cases. So let's go ahead and start. The basics first. We look at inflow, the pump, and the outflow. So we are looking at the venous returns, the veins that get into the right atrium or the atria, and also the coronary vein, in fact, which drains most of the venous return from the cardiac chambers. And in cardiovascular imaging, we are basically looking at all of these. So I've had great cases, sharing some of them. One or two of these have been from my previous fellowship at UW. And then I have some cases over here, which my colleagues have shown me as interesting cases over the last couple of months, and I thought that these would be interesting enough to discuss over here. So let's start with our first case, and this is a 69-year-old patient who presents to the ED with chest pain. And of course, we are doing a CT angiography to evaluate for any pulmonary emboli. So these are the images of the CT. You can see that this is a non-gated acquisition. There is a small hiatal hernia, but as far as the cardiac chambers are concerned, what we are seeing over here are biatrial enlargement. This was correctly pointed out by the resident, but if we pay attention to the other structures over here, what you'll see over here also is that the coronary sinus is very dilated. So based on the findings of biatrial enlargement, echocardiography was recommended. And besides that, what you can also see is the dilation of the coronary sinus. And echo was very interesting. They saw atrial septal defect. The shunt is small, and they could not. When they did the QPQS, they thought that the ratio was a bit more than what the size of the shunt was showing them. So they went ahead and did a trans esophageal echocardiography, and what we can see over here is this again this flow jet on the TE, which suggests that there is a large atrial septal defect. They still could not explain some of these, so they requested a MR to quantify the shunt and also to look at the atrial septal defect, to look at the size of the defect and see if we can give them size of the defect for optional occluder device placement planning. So this was a MR that was obtained, and let's take a look at the MR. There are some interesting findings over here. Um, Again, this is a short axis stack. We are back towards the atria. So we are coming from atria towards the AV valve plane. And what I want you to look at is this part of the atrial septum, and also look at this coronary sinus over here. So if we go further, if you pay attention to this part of that, you can see the coronary sinus is much larger. Normally, this is a structure which measures about 8 to 10 millimeter only. And when we did a phase contrast across the aorta and pulmonary artery, we had a QPQS ratio of 1.4. So again, the question was, can this defect be closed using an ASD occluder device or not? And the key answer to that is that you can close this part of the secondum atrial septal defect, but what we also have over here is a coronary sinus defect. Basically, this coronary sinus is opening into both right atrium and left atrium over here. So I think I'll bring up an article from Radiographics over here, which has been published by our colleagues, Dr. Saima, and they have a great image of how the atrial septal develops and what kind of defects can be seen over here. And this is a great example of how we can see a sinus venous ASD near the superior and inferior vena cava openings. And we can also have, these sinus venous ASDs can be associated with congenital anomalies also. This is the rarest form of atrial septal defect, the coronary sinus defect. But the key finding over here is there is also an associated secondum atrial septal defect, which was not well seen on the transthoracic or transesophageal echocardiography. And MR had this, additional advantage of identifying that for them. So briefly going over the defects, ostium secundum is the commonest. There is increased reabsorption of the septum primum, or the septum secundum fails to occlude the ostium secundum. So we have this ostium secundum ASD. We need to differentiate this from PFOs, which are usually smaller, less than 5 millimeters in size. Ostium primum defects are usually associated with endocardial cardial cushion defects also, and they can be part of atrioventricular septal defects. Sinus venous defects can be associated with anomalous pulmonary venous return. On the right, in case of superior defect, you can have a anomalous venous return from the right superior pulmonary vein, and in case of inferior defects, we can have anomalous venous return from the right inferior pulmonary vein. So these are the additional things to look for when we are talking about atrial septal defects. One thing that they want to know is what is the size of the rim, or is there enough tissue for placement of the occluder device. Typically, you do want a rim to be at least 5 millimeters. And then we have this, can you guys hear me correctly? One of you can answer.
Yes, we can hear you.
Great. Okay, I thought the phone was for something else. That's fine. And then we have this coronary sinus defect. This is the rarest of all. Basically, it can be associated with other defects. And the key finding over here is the unroofing component of that, which indicates that the coronary sinus is draining back into both the atrias near the atrial septum. Because the flow is slow, these may remain undetected over a long period of time. And that's why we might see many of these in patients who are much older. So the key thing is whenever we're looking at an ED or any non-gated chest CT, once we identify biatrial enlargement, I think the key thing is to also look for any anomalous pulmonary venous returns, or what is the size of the coronary sinus, because those will be our clues on a non-gated CT to look at these entities or identify these entities. So then this is our case of an unroofed coronary sinus with the septum secundum atrial septal defect. Like everything, there is a classification system, and this is the most commonly used classification system for these defects. Basically, you are trying to see if there is also a left-sided superior vena cava or not, and then where is it opening into the septal defect. So let's move on to our next case, which is, so if you have any questions, please feel free to stop me and ask as we go forward, because this is supposed to be interactive. You don't have to raise hand, just unmute yourself and ask if you have a question about any of these cases. And I think that will be the best part of this. So we move on to this next patient. He's a 20-year-old who has a history of polyarthritis nodosa, presents to the ET with tachycardia and ST elevation. And this is, of course, again, a non-ECG gated CT. And then we have a follow-up of this was a ECG gated CT based on the findings that we have over here. So I want you to look at these two things over here. This is the diagonal branch of the LAD, and then this is a distal portion of the right coronary artery over here, which we kind of don't see very well on the first phase of this acquisition because of streak artifact which comes in from the mixing artifacts from the contrast coming from the SVC and non-contrast blood coming in from the IVC. So we have these two findings over here. The diagonal is bigger than the LAD, and then we have got this focal outpouching coming from the right coronary artery. If you go back and look at the stack, you can kind of follow this thing back over here. Right, you can see this diagonal coming off, and then as we come down towards the right coronary artery, you can kind of see this structure over here, right next to the right coronary artery. So the suspicion was raised for coronary artery aneurysms, and the patient also was presenting with abdominal pain and some hematemesis. So of course, chest and abdominal CTA was obtained. And what you can see over here are these pulmonary arteries, small aneurysms of the pulmonary artery. In case of abdomen, we can see this, aneurysm of the hepatic artery. Again, we can see this on the catheter angiography selected. And there was also a left gastric artery aneurysm over here. Because there was hemoperitoneum, they went ahead and did a catheter angiography and uploaded this pseudoaneurysm of the hepatic artery. The coronary artery aneurysms, because they were there and the patient was not really symptomatic, they did not really do anything about that. Patient was put on immunosuppressors, and we got follow-up imaging. So this is kind of our follow-up imaging. These are the two images from the initial scan, and then these are the CT images from the follow-up image. Again, you can see that this has, the aneurysm is much smaller in size. Same thing over here, and this one has also smaller in size and probably thrombosed or no longer opacified with contrast. We can see the same findings over here. If we look at the diagonal over here, so this is the diagonal that we are chasing, and you don't see it. And then the right coronary artery, this is where we kind of see how that coronary artery is smaller in caliber. It's very thin. So many of these patients will, if they are, the treatment is, there are no clear-cut defined criteria how to treat them. Typically, if we think of how patients with Kawasaki's will be monitored or treated, aneurysms that are smaller than 8 to 10 millimeter in size will usually regress after medical management. And usually those aneurysms which are greater than 10 millimeter in size do not regress. So those are the ones that can go on to grow over time. This is a image from the same patient at the time of follow-up imaging. This is if you have used heart flow. This is kind of the roadmap that comes with the coronary CTA. So you can see there is no obvious stenosis in any of the big arteries, though there is suggestion of a decreased flow or low flow, which could be hemodynamically significant stenosis further distal to the LAD territory. And because this was so far away and not really concerning, they did not really do anything about this. The plan was to just follow this up with follow-up. There's no evidence-based guideline for management. So obviously medical therapy is what this is usually done. Immunosuppressions, antiplatelet therapy and regular monitoring is done. Surgical intervention is usually done only in selective cases. And there are case reports of almost complete resolution of coronary artery aneurysms. This is an interesting entity to know because typically when we think of aneurysm, we don't really think about them getting smaller. Go ahead. Did someone had a question? Okay. So we'll move on to the next case, and these cases are interesting. So there is this RDR device being used for pulmonary hypertension patients. This is something similar to a balloon pump used in aorta. Only difference is that this balloon pump is placed in the pulmonary artery. It's connected to a reservoir, and there is no mechanical component of this. It just inflates and deflates with systole and diastole. So that's kind of the key, difference in that. And the function of that is that when there is systole, the normal vessel expands, and at that time, this balloon will collapse because of increased pressure. So it allows flow to go across the pulmonary artery, and during diastole, this will inflate and then again will kind of maintain pulmonary flow with that. This is a fluoroscopic image from the implantation, and you can see this pump how it's contracting and changing shape over time. And then these have usually a nitinol anchor, which is anchored in the inferior pulmonary artery, left inferior pulmonary artery. And then there's a balloon, and then this is the drive line, which is placed, which connects to an external reservoir in an abdominal wall, usually placed through the subclavian vein. So this was an interesting case. This is how it should look normally, where a well-formed, well-defined balloon should be seen in the main pulmonary artery. The balloon should be distal to the pulmonary valve, and then this cage, nitinol cage, should be in the descending uh, left lower lobe pulmonary artery. So this is our case, interesting case that we're seeing. Again, you can see this balloon is not very well formed over here. It's kind of not distended. And then this patient had a follow-up imaging. And at the type of follow-up imaging, you can see that the balloon is not even seen. So this is kind of a device failure with the balloon no longer expanding. And then this is fluoroscopy of the same patient, and you can again see the same finding over here. We don't see the balloon at all expanding. We don't even see the balloon. This was an interesting article that we published from our group over here on right ventricular assist devices, and we talk briefly about the ARIA pump over here. The gas usually used is a proprietary mixture, nitrogen, oxygen, carbon dioxide are what usually are there, but it's a proprietary mixture. We don't really know the true composition. Let's move on to our next case. So this is a 22-year-old with history of non-ischemic cardiomyopathy, presumed to be viral, who had ICD implant, and then the radiograph was being asked to evaluate for check lead placement. So we have got two radiographs over here. This is the initial radiograph before the implantation, and then this is the follow-up radiograph over here. We can see the ICD leads in right atrium and right ventricle. And when we see the follow-up radiograph, there is this device which is on top of the mediastinal silhouette. So what is this device? This was something new for us. We had not seen it before. And taking it a deep further, you can see that this is called as a WISE CRT system. And what we have over here is a CT from the same patient. This is the lead. This is usually placed in the left ventricle side of the lead. So typically ICD leads are not placed in the left side, left cardiac chambers. The reason being there is increased risk of thromboembolism and infections. So they're typically placed in the right atrium, right ventricle, or a coronary vein through a coronary sinus. This is unusual that it is placed in the left side of the system. And the key thing over here is this is the generator. This uses ultrasonic waves to communicate with this, and this lead then stimulates the left ventricle from the left side. This is an interesting article where they did a meta-analysis and identified that leadless endocardial LV pacing recent remission is very effective for heart failure patients who failed conventional CRT therapy. And that is the key thing about is these are patients who have failed previously attempted CRT treatment. And this can be a rescue therapy in these patients. So this is an illustration from the manufacturer where they describe how this is placed, the battery, the transmitter, and the electrode. And this is basically using the subcutaneous transmitter, which generates ultrasound pulses, which are received by the receiver in the left ventricle side. And it converts those ultrasonic waves into electric energy to stimulate the. So this is a new device. Have you guys seen this before, or are you guys using this? Any experience with this?
I've seen just one case so far, so it's interesting that this is the second case I see.
Mhm.
I'm not sure how new is this.
Yeah, I think that's the key thing is very important because conventionally we would always say that we shouldn't be seeing leads on the left side of the system, but here we have it. Good thing is that this is mainly for those who have failed. So digging a bit further into the manufacturers and the FDA approval side, you can see that these are being used in those patients. These are the indications of this device. These are used in those who have a previous coronary sinus lead implantation or was lead implantation was unsuccessful. And they define as two basic criteria: those who have previously untreated and those who are at a higher risk for venous occlusion. And this is where this is coming from. I thought this was interesting to discuss because as we are constantly evolving these techniques, newer devices will come into play. And I think these web seminars are a great way to talk about this, anything that new that we see in our practice.
Uh, I agree. I saw this case originally in an X-ray, and I thought was
Mhm.
a fragment, like a foreign body initially.
Mhm.
So
Yeah, yeah,
yeah, so it's interesting that we have to know these things because otherwise you start making the wrong calls.
yeah. Great. So I think I just thought I will bring up this companion case just to show, where the ICD leads are placed on the arterial side of the system. We can see both the leads in the ascending aorta. So in this case, the leads were in the aorta. The first lead was near the AV aortic valve, and the second lead was actually in the LV apex. And I think key thing is to identify these on or suspect these on radiographs, and if the index is high, get a non-contrast CT for confirming this finding. These needs to be taken out. We'll see how the imaging evolves in these patients with these left-sided, device implantation. So moving on to our next case, this is a 57-year-old patient who presents to the ED with chest pain. And this is the CT of this patient. You can see the right coronary artery, sorry, is very big. If we come down over here, and the left coronary artery, where is the left coronary artery, or is it even there? It's kind of, there are tortuous vessels over here, and then we see this flow of contrast in the pulmonary artery. So the key finding over here is this is an aortic phase study. The main pulmonary artery does not have contrast, but this part of the pulmonary artery over here has very dense contrast, same density as the ascending aorta. And then what we are also seeing over here is this very tortuous and large right coronary artery. So I think these are two very suspicious findings to suggest that one, right coronary artery is big and it is the dominant vessel supplying the coronary circulation. And second, we need to do further investigations to see what's happening to the left coronary artery. Although you can kind of make a guess over here that this is anomalous origin of left coronary artery from the pulmonary artery. And what we're seeing here is actually a steal phenomena. All the flow is coming through the right coronary artery, and this dense contrast is actually going through this left coronary artery into the pulmonary artery. So this puts at the any territory supplied by the left coronary artery at increased risk for hypoperfusion, and sometimes that can be the cause of chest pain in these patients. Um, this is collateral circulation is happening over here, and then typically what we see in these patients are these are mostly seen in younger kids, infants. Rarely we see that in adults, but once we see them in adults, I think we got to think about could there be any perfusion anomalies or could there be any decreased contrast enhancement of any segment of the left ventricle myocardium. And that could be a clue on a non-gated CT to suggest that there could be, this patient could be at increased risk for myocardial ischemia from that. And that's what is happening over here. This patient also has, if we go back to look at the mitral valve, there is some thickening over here. We can't really talk about anything more than that. So this patient underwent an MR before surgery to evaluate the mitral valve better. And what you can see over here is this mitral regurgitation, mitral valve thickening. There is also aortic regurgitation. And then when we did the delayed enhanced images, we can see these focal areas of delayed enhancement. So this is nearly transmural in the anterior septum, and then this is subendocardial in the anterior wall. And these were probably the reasons for the chest pain presenting in these patients. So the patient is scheduled for mitral valve repair and surgery. Surgery can be complex in these patients. Typically, what they would do is they would ligate depending upon the stage of the patients. Sometimes they might also do a Takashi procedure. Otherwise, they could do a ligation of the pulmonary artery, anomalous pulmonary artery, coronary artery from the pulmonary artery, and then do a coronary artery bypass graft. That is the most commonly used thing in these patients. So this was interesting from an ED perspective that you could see this, contrast, dense contrast coming into the pulmonary artery, which is the key to tell us or make us aware of this entity. So let's move on to the next patient. This is a patient who had AML, who had relapsing disease, was initiated on cytoreduction, and was being treated by gilaritinib, and who presents to the ED with increasing chest pain and elevated troponins. So we did the coronary CTA in this patient in the ED, and this is again the roadmap from heart flow, which does not identify any area of large stenosis in the coronary arteries. What we see is, probably less than 50% mild stenosis. Again, these are the ones that we should look with a bit more carefully because there might be areas of soft plaque which we may not see very well or we may not appreciate very well. And that could be a cause. But again, there is no hemodynamically significant stenosis. So then the question was, could there be some drug-induced disease over here? And for that, this patient underwent an MR. This is a T2 weighted image. You can see the increased signal intensity compared to the normal myocardium. And then this is a T1 weighted image over here. Again, the T1 times were elevated in the myocardium. And then this is kind of what we did, the ECV calculation. So this is very interesting part is that, the T1 post numbers can be variable depending upon when you are doing the post contrast images. Typically, you want to do it at a predetermined time on most of your scans. In our case, this is usually happening around 20-25 minutes. after the short axis stack has been, MDE stack has been done. So elevated ECV, elevated native T1, and decreased post-contrast T1 times, all findings which are suggestive of myocarditis. So this was a patient with drug-induced myocarditis. Again, the lead enhanced images, you can see the areas of mid-myocardial enhancement, epicardial enhancement in the apex. Again, seeing it over here. So this meets the T1 and T2 criteria for identification of myocarditis. Let's move on to the vessels, and I think intravascular tumors is an interesting component of cardiovascular imaging. The main thing to differentiate is, of course, thrombus or plaque thrombus complex. And are there any things that would suggest that this could be a tumor rather than being a thrombus? So what are the different features that can suggest that? Is there an adjacent extraluminal component, multifocality, wall thickening, and then vessel enlargement? These are criteria that can be useful to identify or differentiate tumors from other benign entities. So whenever we see a vascular lesion, I think these are the things we want to look for because these could be the clue towards the vascular lesion that we're seeing not being a thrombus. And I think presence of enhancement is something that we can see if we have done multiphasic acquisition. Typically, this will be done on an MR, or sometimes you can also do a delayed enhancement. Iodine content CT can also be useful. So this is a case from my fellowship, and some features which can be very useful, rarely seen though, are attenuation. This is a patient with angiomyolipoma of the left kidney, and we have this fat-containing lesion in the right pulmonary artery. And this was actually a metastasis from this AML in the left kidney. So this has always stuck with me. We see it very rarely, but once you see it, I think the diagnosis becomes much more clear. Moving on to the next patient on this same theme of vascular tumors. This is a 55-year-old patient with non-small cell lung cancer. This is the initial scan. We can see a large left hilar mass, which is encasing the pulmonary artery, left lower lobe bronchus, small left effusion, mediastinal shift towards left. Initial presentation. And then this patient presented with seizure-like activity on follow-up, and head MR was obtained, and this area was identified. So the question was, could there be a tumor extension somewhere? And then we did a follow-up imaging based on that. So this is the MR. We want to look at the left side chambers because if you're thinking of an embolic cause, it could be from the left side. And what we can see over here is clearly this large mass which is extending into the left atrium. Again, on the SPECT CT, this mass is seen extending into the left atrium. Probably this was the source of the emboli in these patients. So MR can be very useful. If we don't have MR, we can also do delayed phase cardiac CT imaging to see if there is any enhancement in that. How dual energy can sometimes be useful. So this is a patient who has an LVAD who develops aortic root thrombus, stasis thrombus in the sending aorta, which can send off emboli again. And the question is could this be vegetation? Could this be thrombus? It can be tough to tell that unless the patient has symptoms of infection. But we can use iodine content sometimes to look at that. This is a follow-up of the same patient. This is much smaller in size. Again, that's a clue towards this being rather thrombus. And while the iodine content is very low, average is like less than 0.5 milligram per meter square. So this is dual energy has been used in characterizing cardiac thrombi. Similarly, we can use that sometimes or try to use some of those features for differentiating vascular lesions also. This is a unfortunate patient who had a large pulmonary artery sarcoma. They went ahead and did a extra pleural pneumonectomy on the left side, and then they identified on the follow-up imaging. This lesion was identified in the main pulmonary artery. So we did a MRA, and we can see this is very heterogeneous in its enhancement. And then going back to the original PET, you can identify clearly that this was present at that time also. And this was a separate metastasis in the pulmonary artery from that large sarcoma. Interesting entity that we'll be seeing probably more of these. This is a surveillance CT in a patient who had a history of right upper lobe lung cancer, post resection, and also received radiation therapy. And then now we have this large filling defect in the right pulmonary artery. So the difference was, could this be thrombus or disease recurrence? PET was obtained. This is not FDG avid. This is thrombus. So then the question is, should these thrombi be treated or not, or how to treat these, how to manage these stem thrombus? So our colleagues from NASCI have a great article on this, what to do and how to recognize that. And they describe these certain characteristics which can be very useful to differentiate or identify uh, stem thrombus and differentiate this from disease recurrence. One is that these filling defects can be usually non-occlusive. They thrombi tend to have an obtuse angle. Um, they can have eccentricity, and thrombus is typically present in the RT volume. So if you can go back and look at the RT radiation therapy planning images, we might have a clue to that. And they suggested that most of these patients also had CT findings to suggest radiation-induced fibrosis. So there is probably a component of vascular injury which is contributing to, this finding in these patients. Okay, so the last case. This is a 25-year-old patient who is post-heart transplant, and they identified abnormal strain imaging on echocardiography. You can see this in the anterior wall and septal wall. There is abnormal strain. When the global longitudinal strain is less than 16%, I think then that's when they consider it abnormal. And MR was obtained for this. So typically these patients will undergo surveillance imaging after transplant, which would include right heart catheterization and biopsy. Also, coronary angiography is also obtained many times. And then MR is a very useful imaging modality to evaluate these patients because they are not going to be symptomatic because of denervation. They may not have same symptoms. They may not present with same symptoms of chest pain. And what we are seeing over here is this heterogeneous area of delayed enhancement in pretty much the whole anterior septum at mid cavity. This is a papillary muscle level, and this is all probably cardiac allograft vasculopathy. Different patient again over here, same kind of finding. We see some area of myocarditis, and then this is that area of delayed enhancement in the inferior wall. So the key thing in these is that many of these patients may have normal appearing coronary arteries on coronary angiography, catheter angiography, and that is because of remodeling, and we may not see that. So this cardiac allograft vasculopathy is a panarterial disease which is typically limited to the allograft. It can be because of cellular or antibody mediated rejection. The antibody mediated rejection and then they may present with elevated C-reactive protein also. So when they do, intravascular ultrasound or OCT, then they might see a concentric hypertrophy of the intima in the epicardial coronary arteries. Unlike atherosclerosis, there is also medial disease, which helps differentiate this from atherosclerotic causes of that. So what's the future of this? I think we're going to see a lot more of these patients getting imaged with coronary CTA as the data is coming in, and they're already talking about how non-invasive imaging with coronary CTA can be very useful in identifying allograft vasculopathy. And this is a very interesting article that was published in 2022, which also looked at CT-derived, FFR in these patients. They suggested that FFR values fall or decrease in FFR is can be seen even before we start seeing visually start seeing plaques. So this is very interesting, and probably we might be seeing more of this. Thank you. Any questions? All right. Thanks a lot for joining. I hope you enjoyed these cases, and we'll see you next time.
Thank you very much.
Thank you.
Thank you.